Hello, everyone. My name is Christy Amobi, and I work with Excision. Welcome to our clinical education webcast. I'm delighted today to welcome Dr. Marco Trovò from Azienda Sanitaria Universitaria Friuli Centrale in Italy to discuss his clinical experience delivering non-invasive radiation therapy in a single fraction to treat early-stage breast cancer patients and closely monitor follow-up. Since breast cancer typically represents 25% or more of patient volumes in most radiation oncology clinics, there could be a significant positive impact to improve outcomes, increase patient satisfaction, reduce wait times, and additional operational savings if providers were able to deliver radiation treatments faster and more effectively. Dr. Trovò will explain how he's been working with the new GammaPod Stereotactic radiotherapy system to deliver a highly conformal full course of radiation treatment in a single fraction across 3 patient groups, including pre-op, post-op, and as a tumor boost. Dr. Trovò will be available following the presentation for Q&A. Thank you again for your attention, and with that, I'll hand it over to Dr. Trovò.
Good morning. I would like to thank the Excision for inviting me to talk on our program of single fraction radiosurgery for breast cancer. So in our department, we have three single fraction protocol, and I will talk about that now. So the first protocol is on post-operative partial breast irradiation. The second protocol is a preoperative radiosurgery for early-stage breast cancer, and the third one is the single fraction as a boost. So, talking about the first protocol, the post-operative radiosurgery to deliver partial breast irradiation, we have a study that wants to demonstrate the safety of a high-dose stereotactic radiotherapy delivered in single fraction to the tumor bed, and we use the GammaPod system, which is a novel technology designed to deliver a high focus dose to the breast under stereotactic immobilization. So the total dose is 17.5 gray, prescribed to the 95% of the PTV, with imaging, planning, and dose delivery mostly completed within an hour session. The target is defined by contouring the surgical clips and adding 10mm margins to create the CTV. And the PTV includes the CTV plus 3mm margin, accounting for the stereotactic geometric uncertainty of the GammaPod. So the primary endpoint of our trial is to obtain a rate of acute and late treatment-related toxicity less than 14%. And so we design a single-arm phase 2 clinical trial using the 2-stage Simon method. It means that we want to obtain less than 7% of grade 2 or more toxicity in the first 40 patients. If we reach that goal, the second phase can be set, enrolling up to 148 patients. Here are the inclusion criteria. So there is the group 1, which is very simple, is according to the ISTRO selection criteria. So mainly age more than 50 with invasive ductal carcinoma and early stage pathological stage, T1, T2, and 0. A unifocal tumor, any grade. And then, according to our previous experience, there is a group 2, in which patients are more than 70, and if this is the case, they can be affected by lobular carcinoma, N1A disease, or the tumor can be multifocal within the same quadrant. Here you can see the treatment procedure. So first step is the multidisciplinary meeting discussion, the clinical evaluation in radiation oncology department. Once the informed consent is obtained, patient is going to be treated in two parts. The first part is the dry run simulation, and I'll show you, and then the treatment delivery. So we use the GammaPod to treat these patients, and as you can see, here you have many cup size. This cup fits the breast, and then there is another cup, which is the external cup with the stereotactic localizator. And between the two cups, the inner and the outer cups, the vacuum is obtained. So in this case, the breast is completely mobilized and the motion is managed. Patient is simulated in the prone position. Here you can see the stereotactic localizator, and the surgical clips here are well visible. After the simulation, patient is treated in the GammaPod system in the same prone position. So the primary endpoints of our study are acute and late toxicity, namely the skin erythema, the breast edema, induration or fibrosis, telangiectasia, atrophy, or breast pain. Secondary endpoints of our trial are the classical survival outcomes. So we treated this patient in protocol in January 2022. We screened 92 patients. 15 were excluded, 3 because they refused treatment, 5 were unfit for the GammaPod, and 7 were excluded after the CT simulation. So in almost a year, we treated 77 patients. And these are the patient characteristics. As you can see, the median age was 69. Two-thirds of patients had a good performance status according to ECOG. And many patients had some cardiological or metabolic comorbidities, including diabetes, stroke, angina, etc. Here are the tumor characteristics. As you can see, the majority had a T1 and 0 pathological stage, and the majority of patients had a ductal invasive carcinoma and were luminal tumors. Here are the treatment characteristics. The median PTV was 48 cc with a large range between 13 and 100 cc. The mean PTV dose was 18.6 gray, and the median delivery time was of 36 minutes. Coming to the second protocol, which is the preoperative radiosurgery for early-stage breast cancer, we prescribe a very high stereotactic radiation dose, starting from 30 up to 36 gray in single fraction, delivered to the tumor only with the GammaPod technology. The target is defined by a fiducial marker, which is placed into the tumor with ultrasound guidance. So the GTV includes the fiducial markers and the tumor above, and the PTV is created by adding 3 millimeters margin to the GTV. Surgery is performed 3 to 4 months after radiotherapy. The endpoints are to obtain, the major endpoint is to obtain a rate of acute and late treatment-related toxicity less than 14%. And also here we design a two-stage Simon phase 2 clinical trial, in which for the first 40 patients, we want to have less than 7% grade 2 or higher toxicity. If this goal is reached, the enrollment goes up to 148 patients. So here, in this case, inclusion criteria are a little bit stricter. So it's T1, T2, and 0 tumors, age more than 50, and in this case, HER2 receptor must be negative. So we enroll only luminal A or B tumors, and very important, a diagnosis. The tumor has to be detectable at ultrasound in order to put the fiducial marker. The procedure is a little bit more complex because we want to have a very good baseline imaging, including magnetic resonance, to assess the extent of disease. Then, once the informed consent is obtained, the fiducial marker is put into the tumor thanks to the ultra guidance guide. And the cap fitting dry run simulation treatment delivery is done the same day. So after radiotherapy, we get a clinical evaluation 4 weeks after radiotherapy, a new restaging to assess the radiological response, and then surgery 3 to 4 months after radiotherapy. Primary endpoints are acute LN toxicity, defined as skin erythema, breast edema, induration, telangiectasia, atrophy, and breast pain. Secondary endpoints beyond the classical survival endpoints are the rate of pathological complete response and the role of MRI in predicting treatment response. So in the study period from January 22 to March 23, we screened 53 patients. 11 patients were excluded, 5 because they refused treatment. And so we treated 41 patients, and 30 patients already underwent to surgery. Here are the patient's characteristics. As you can see, the median age is a little bit lower. The majority of patients had a good performance status and the comorbidities were pretty low. The majority of patients had a T1 tumor with ER positive, HER2 negative disease in all the patients. As you can see, the PTV was pretty small, only 5.5 cc with a range between 1.9 to 32 cc. The median mean PTV dose was 33 gray. The median delivery time was 13 minutes according to the PTV size. And finally, at the end, the radiosurgery as a boost for high risk of recurrence patients. So we decided to enroll only PT1, T2, N0, and 1A, meaning patients who do not need the radiation the supraclavicular fossa. The prescribed dose in single fraction is 7.5 gray. And the following day, patient receive whole breast radiotherapy in 15 daily fractions. The primary endpoint is to have a rate of acute and late treatment-related toxicity less than 25%, and so we design a simple single-arm phase 2 clinical trial, and the goal is to enroll 70 patients. Inclusion criteria are pretty simple, meaning that the characteristics of high risk for recurrence are one of the following: age less than 50, molecular subtype triple negative, or grade 3 disease, or the presence of positive or close margins not treatable for further surgery. Primary endpoints are acute skin toxicity, defined as follows, and secondary endpoints are the classical survival endpoints. We started this project in June 2022, and 30 patients were screened. Only 4 patients were excluded, and So 26 patients were enrolled. As you can see, the median age is lower, 50 years, with a range between 37 and 69. All patients had a good performance status, and almost nobody was affected by comorbidities. The large majority of patients had only one risk factors. That was the age less than 50 years in the majority of cases, triple negative disease in 3 cases, and high-grade tumor in 5 cases. So no positive margins were enrolled. The median PTV was 36 cc with a large range. The mean dose was 8 gray, and the median delivery time was 14 minutes. So after 1 year of experience using the GammaPod system to deliver a single fraction radiosurgery to the breast, we can affirm that the safety is very high. So this approach is associated with a very good toxicity profile. And in general, patient satisfaction is also very high. Thank you for your attention.
Hi, Dr. Trovò. Thank you so much for that excellent presentation. Can you hear me okay?
Yes, very good.
Fantastic, fantastic. So now we're going to open up to the Q&A. As I mentioned in the introductory comments, if you have any questions at all, you can go ahead and enter those in the GoToWebinar chat window, and I will moderate those here for Dr. Trovò for the next 5 to 10 minutes. I do see questions coming in now, so let me just turn my attention to those quickly. First question, how have your patients responded to having only one treatment session?
I must admit that patients were really satisfied in concluding all the radiotherapy session in only 1 day. So this was very helpful because maybe some patients are old, or even the young patients that have to take care of children or old parents appreciated a lot this very short course of radiation therapy.
Okay, thank you. Next question, is there any patient-specific QA, quality assurance?
We do perform the QA for every single plan. Particularly, we do this in 2 steps. The first one is during the dry run simulation. So we get sure that the GammaPod is really suitable for that patient. And also we repeat the quality assurance after the plan is delivered to be sure that the delivered dose is very close to the planned dose.
Okay, thank you. Next question, is there any image guidance?
No, we don't need image guidance because this is a pure stereotactic guided machine. So the challenge was to be sure that the target was absolutely identified by the stereotactic guidance, and also because the tumor motion is completely managed, we don't need actually image guidance to do that.
Okay, thank you. Next question is around your implementation. Did you have any implementation challenges that you can describe in more detail, or was the implementation straightforward?
Okay, the GammaPod system is really simple actually in its design and its invention, because it's designed to deliver only partial breast irradiation. So there are not many possibilities to change the plan design. So the major implementation challenge was related to the organization of the department itself. because the new technology needs to be fit in a previous organization, which is completely different, as I show you. So it's a management challenge, actually, more than a clinical implementation challenge.
I see. Yeah, that's the case with many new system implementations. So that makes sense. Next question is around some of the results that you're seeing. What results are you seeing regarding toxicity and local control?
Okay, so we started treatments a year ago, and so we will present in a few days the first results in the first 40 patients of treated in a postoperative setting in single fraction, and the results were, I will show you, they are excellent. So we had actually no grade 2 toxicity, so with a very small and short follow-up, of course, but this allowed us to go on in enrolling patients, and so in almost a year we treated more than 150 patients without any grade 3 or higher toxicity. So this is the GammaPod used according to our protocols, of course. The toxicity profile is very safe.
Okay, thank you. That actually is a good segue to the next question. You mentioned there's 150 patients. Is that across all 3 patient groups with the pre-op, post-op, and the boost, the APBI, SBRT? The person's question is related specifically to, since the installation, how many patients total have been treated in each of those groups? Was it more patients than in your trials that you presented?
We treated almost 80 patients in the postoperative single fraction radiotherapy, PBI. 44 patients underwent preoperative radiosurgery to the tumor in situ, and almost 26 patients received one single fraction as a boost, followed by whole breast radiotherapy.
Okay, thank you. Have you seen any impact? The next question, have you seen any impact to your wait time so far with regard to your patient groups?
So it's very simple, because if you consider that usually instead of one fraction you perform or you prescribe the 5 to 15 fractions, it means that the number of sections dramatically goes down, or you reduce the number of fractions, of course. Yes.
Okay, thank you. Next question, are you doing any particular protocol or workflow around breath control for your patients that you're treating on the GammaPod?
No, the GammaPod itself managed completely the motion of the organ, thanks to the cup, the vacuum that's obtained between the 2 cups. So the tumor is completely immobilized.
Okay, sounds straightforward.
That's why we can have a very, very small margin between our, the PTV margin is so small.
Right, okay, makes sense. In your workflow, how do you decide if you're going to treat on the GammaPod or on a linear accelerator?
Okay, so we use GammaPod only for clinical trials. So all patients that can be included in those clinical trials are screened for the GammaPod treatment. Actually, between 15 and about 15% of patients will not be treated to the GammaPod, enough for the case because they refuse a clinical protocol, and the other 7% of patients are not fit to do that, or because patients are, for instance, too old to be fitted in the GammaPod, or in some cases the tumor is too posterior respect to the focus of the radiation to the GammaPod. So in that clinical cases, the dose distribution does not is not so good and so safe to do that. So this is about 7% in our experience.
Okay. Follow-up question just for me, do you anticipate being able to move, some of your patients, your non-clinical trial patients, into the GammaPod? And if so, when do you think that would be, you would be able to do that?
Okay, you can use the GammaPod without clinical trials, of course, if you want. But we decided to, because the organization of the department is pretty complex, so we decided to take advantage of the very high conformal radiation dose of the GammaPod to treat that patient in one single fraction.
Got you. Okay. Next question, kind of turning our attention back to your implementation. Can you describe the overall, timeline for the implementation, the installation, the commissioning, the acceptance process related to your center?
There are two things to be said. The first one is that we were the first hospital in Europe to have a device like this, so everything was new, and the regulation between Europe and the United States are so different that we had to implement every single step. And so, being the first one in Europe, we decided to be very safe in the implementation of this. The second one is that the installation took place during the COVID pandemic situation, and so this didn't help much. So I can say the commissioning took some times, like months. And the go live actually was very quick, because we, thanks to the American colleagues from Dallas and from Maryland University, we started treating patients in only 1 week.
Okay, thank you. We have time for 1 or 2 more questions. So if you have any additional questions, go ahead and submit those in the GoToWebinar chat window for me to moderate for Dr. Trovò. Next question is around the recommendation of the system, the cost versus the value. I know that there's a lot of differences throughout the world in terms of the cost of equipment and so forth. Do you recommend the system related to the overall value of the solution?
It depends from what point of view you see the deal. Sure. I'm not talking about the reimbursement laws or regulation, because they are completely different.
Right.
So, but if I were a patient, I think the value of being treated in one session is much higher than being treated in 15 sections.
Great. Okay, and final question. You had mentioned that you would be presenting some data from one of the trials upcoming here. Is that at the ASTRO conference coming up here in Vienna? Yes. Okay, fantastic. So for all of you on the line, if you're going to be in Vienna, make sure to you can make sure to see that data at ASTRO. That is our final question, Dr. Trovò, for today. On behalf of Excision, I just would like to thank you again for your time and for your participation today. This has been very informative. And for those of you on the line, just a quick housekeeping again, you will receive a copy of the recording for today's event. You can feel free to share that with anyone who may not have been available today in your center. And if you have any additional questions, please just go ahead and respond to that message, and we'll make sure that we can try to connect you here with Dr. Trovò. Again, thank you so much for your attention. And with that, I will close today's session.
Thank you.
Thank you.